Hello, I'm Professor Susanna Banerjee, Consultant Medical Oncologist at the Royal Marsden NHS Foundation Trust and Professor in Women's Cancers at the Institute of Cancer Research in London, UK. Welcome to this podcast series titled Breaking the Silence, Navigating Advanced Endometrial Cancer. So during this series, we will go through a total of 6 episodes: the story so far, the long and short of clinical development in endometrial cancer, and then episode 2, more than high and low risk, how we have learnt that endometrial cancer is not a single malignancy, and then moving on to the hottest topic in endometrial cancer: where is the therapeutic landscape moving to, and what are the data to support this? Next episode will be tackling how to combine or not to combine chemotherapy and immunotherapy. Is that the question in endometrial cancer? And then we'll go on to beyond primary treatment. How else can we benefit our patients through a holistic approach to care? And finally, we will tackle in the next episode living with endometrial cancer, understanding patient perspectives to improve overall care. So let's start with today's episode. For over a decade now, the standard of care options we had to offer our women with advanced or recurrent endometrial cancer has been chemotherapy or hormonal therapy. Now, if we take the ESMO endometrial cancer guidelines, they indicate that for first-line treatment, the standard of care is chemotherapy with carboplatin and paclitaxel 3 weekly. For patients who have relapse or progression post-platinum and paclitaxel, the options include re-challenging with platinum or single-agent doxorubicin or paclitaxel. Hormonal therapy is also an option, and this includes progestins, aromatase inhibitors, and is considered for patients with low-grade endometrial cancer in the first-line setting, if there's a low burden of disease or indolent disease, or as the next line post-chemotherapy. And treatment till the immunotherapy era for endometrial cancer has generally not been biomarker-directed. Patients have received chemotherapy irrespective of histology or molecular features beyond the consideration of estrogen receptor or progesterone receptor status. The treatment landscape of advanced recurrent endometrial cancer has transformed over the last 5 years. And in 2023 alone, we have seen the results of 4 phase 3 trials in the first-line setting. The standard of care is changing in first-line chemotherapy-naive patients, post-platinum for recurrent advanced disease. And as more patients receive immunotherapy, we need to identify which are the most effective treatment strategies post-immunotherapy and also targets beyond immunotherapy. So for the remainder of this episode, I'll summarise some key concepts of trials of immunotherapy or other targeted therapies and introduce the question of how we treat our patients for progression post-immunotherapy. And this will be discussed more extensively in more detail in subsequent episodes. But first, I must mention the significance of molecular classification in endometrial cancer. So in 2013, the Cancer Genome Atlas Research Network in endometrial cancer was available, and it's been pivotal to the recognition of 4 molecular subgroups: polymutant microsatellite instability, MSI, no specific molecular profile, that's NSMP, and P53 abnormalities. Molecular classification does have prognostic and predictive implications, and we're learning much more about this with translational research and clinical trials. An integration of molecular risk factors with clinicopathological factors in endometrial cancer impacts on risk stratification decisions, patient selection for treatment, and it has the potential to reduce both over and under treatment. So we'll hear more about this in subsequent episodes. So now we are in the era of treatment progress in endometrial cancer. Immunotherapy is changing the standard of care. So what I'd like to do is mention 3 key trials that have changed practice and led to regulatory approvals in the advanced recurrent relapse progression post-platinum therapy scenario. So that's the Keynote 028, the Garnet study, and Keynote 775. So just to set the scene, approximately 30% of endometrial carcinoma have evidence of microsatellite instability high, or DMMR, and that's mismatch repair deficiency. What does that mean? Well, inactivation of certain proteins, so MLH1, MSH2, MSH6, and PMS2, germline or somatic mutations or epigenetic silencing states, that we know that in that situation, immunotherapy is more likely to work, and it gives patients the opportunity to have tailored therapy. So with Keynote 028, that's of pembrolizumab monotherapy in the microsatellite instability high group, the response rate was 48%. Median duration of response not reached. Pembrolizumab was approved by the FDA for MSI high or DMMR endometrial cancer for women who have progressed after systemic therapy. For the Garnet study, this looked at the PD-1 inhibitor, so similar to pembrolizumab, a PD-1 inhibitor called dostarlimab as monotherapy. So here in the DMMR MSI high population, the response rate was similar, 45%, and the median duration of response not reached. And EMA approval was obtained for dostarlimab for the DMMR MSI high recurrent advanced endometrial cancer patient group who have progressed on or following prior treatment with platinum-containing regimen. And then there's Keynote 775 of lenvatinib and pembrolizumab, so non-chemotherapy option in advanced recurrent metastatic endometrial cancer for those patients that have had one prior line of platinum. So it's this combination versus chemotherapy, doxorubicin or paclitaxel. Lenvatinib is an oral multikinase inhibitor that targets anti-angiogenesis, so VEGF receptors, FGFR, PDGFR, and also RET and KIT. And this study, which we'll go into more detail in further episodes, has shown efficacy in terms of progression-free survival and overall survival, and there was FDA approval in the MMR proficient group and EMA approval irrespective of the mismatch repair status. So what I'd like to now discuss is the studies which have been carried out earlier on in the patient pathway, in the first line setting. And we heard in 2023, earlier in 2023, the results of the NRG 018 study and the Ruby trial. Now, there are some differences between these trials in terms of patient characteristics and inclusion criteria, but essentially it's looking at PD-1 inhibitors with carboplatin and paclitaxel followed by maintenance. So Ruby looked at dostarlimab with carboplatin and paclitaxel followed by dostarlimab, and the other arm was carbotaxel placebo and then placebo maintenance. And Keynote 868 NRG-GY018 basically looked at pembrolizumab in the setting that I described. So to highlight the point, which we'll discuss in subsequent episodes, these two trials transformed the treatment of women in this setting and also will help guide treatment decisions for clinical trial development going forward. So, for example, in the Ruby study, the primary endpoint looking at progression-free survival in the mismatch repair deficient group, MSI high, the hazard ratio was 0.28 with the addition of dostarlimab, and in the overall population it was 0.64. If we look at pembrolizumab, we see the same signal of activity of adding in PD-1 inhibitors early on in the pathway. So in the DMMR population, the hazard ratio with pembrolizumab was 0.3, and in the pMMR population, it was 0.57. So later on in 2023 at ESMO, we heard the results of two further trials, ATTEND and DUO-E. ATTEND is a phase 3 study looking at atezolizumab, an anti-PD-L1 inhibitor, to standard platinum-based chemotherapy in that first-line space. And this study showed that there's activity of a PD-L1 inhibitor in this setting. It confirms the outstanding efficacy of immune checkpoint inhibition in combination with chemotherapy in patients with advanced recurrent endometrial cancer, in those with MMR deficiency. And next, we heard about DUO-E, and this is the first phase 3 study addressing the addition of PARP inhibitor maintenance therapy in endometrial cancer. Immunotherapy and chemotherapy combinations, I've just summarized, have shown activity in this space, particularly in the dMMR disease, and adding a PARP inhibitor may improve outcomes. And in DUO-E, there was shown a statistically significant improvement in progression-free survival for chemotherapy plus the PD-L1 inhibitor durvalumab, followed by durvalumab, or durvalumab and olaparib, compared to the control arm of chemotherapy alone in patients with newly diagnosed advanced or recurrent endometrial cancer. So adding olaparib to durvalumab actually enhanced progression-free survival benefit in the pMMR subgroup and not in the dMMR group in exploratory analyses. So some of the key questions arising from what I've just discussed is, can some patients have immunotherapy monotherapy first line prior to having any chemotherapy? So this will be addressed by two important studies, and I would like to highlight those now. So the key studies to address the question about immunotherapy monotherapy in the first line setting is Keynote C93 and EN15, which is a phase 3 randomized trial of pembrolizumab versus platinum doublet chemotherapy in the first line dMMR, so MMR deficient space. And another study, which is a Dominica study, EN13, is a phase 3 randomized trial looking at chemotherapy alone versus dostarlimab in that first line dMMR setting. So very important studies about non-chemotherapy options in the first line setting. And another important study is EN9, LEAP-001, which is a phase 3 randomized open label study of pembrolizumab with lenvatinib versus chemotherapy for first line treatment in advanced or recurrent endometrial carcinoma. But what about targets beyond immunotherapy? It is such an exciting time. There certainly is progress and signals of activity beyond immunotherapy. And I'd like to mention and introduce antibody drug conjugates in this space. For example, targeting HER2. So in the Destiny Pan-tumor study that was presented this year, trastuzumab deruxtecan, the response rate was 57% in endometrial cancer, so all comers post-platinum-based therapy, and the duration of response was not reached, and the progression-free survival was around 14 months. But there are other targets of interest with ADC, so the folate receptor, and we heard at ESMO 2023 of luveltamab tazevibulin in an early phase 1 study, and there's encouraging initial activity. There's also interest in ADCs targeting TROP2, and what we've seen in this space is exciting, but what's important now is where we go. And there is a phase 3 study of a randomized trial looking at a TROP2 ADC called MK2870 monotherapy versus treatment of physician's choice in endometrial cancer in patients who have received prior platinum-based chemotherapy and immunotherapy. So in the final few minutes, what do we do following progression on immune checkpoint inhibitors? So how about re-challenging with immunotherapy monotherapy? So I think the key distinction here is progression or relapse whilst receiving a PD-1 or PD-L1 inhibitor versus cessation of these drugs and then developing relapse. What about combinations? What about lenvatinib and pembrolizumab post-IO monotherapy? And what about DDR pathway inhibitor combinations, so PARP inhibitors or ATR inhibitors? And I'd like to mention a study that's about to open in endometrial cancer for those patients that have had prior immunotherapy. And we are looking at the ATR inhibitor ceralasertib with the PD-L1 inhibitor durvalumab within the ATARI trial, which is due to open shortly in the UK and Canada. So other things that are important are really trying to develop new drugs beyond ADCs and immunotherapy. But what I'd like to summarize for the story so far is that we are in the era of change for the treatment of women with advanced metastatic recurrent endometrial cancer. Immunotherapy containing therapy has transformed the post-platinum therapy and in 2023 first-line treatment. There are promising treatments on the horizons. ADCs, for example, and others beyond discussion for today, but we will tackle in further subsequent episodes. So immunotherapy combinations like dual checkpoint blockade, for example, CTLA-4 and TIGIT. Alongside survival and efficacy, hand in hand, I'd like to emphasize that we also need to manage and minimize and mitigate toxicities for women living with endometrial cancer. So thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.